Ms. Graham.
Thank you. We were on page 6 of your provisional report, and I'd just like to finish the last injury that you've noted on the left arm.
So
And
over,
if we'll just get that on the screen. So that's over there onto the next page, number 19, please. Here we are. Over the back of the proximal phalanx of the index finger. That one.
so over the back of the proximal phalanx of the index finger. So the index finger is your kind of forefinger. The finger is made up of 3 different small bones, the 3 different phalanxes. You can see if you can see the lines on the joints of your finger, in between each of those is a tiny little bone. So we normally classify them as being the proximal, the middle, or the distal phalanx. So in this case, it's the proximal phalanx, so it's the one that's closest to the knuckle. So over the front of that, there was another flapped superficial laceration measuring 0.6 centimetres in length and flaps superiorly. So that just means the flap is at the upper part of the finger rather than towards the knuckle.
So you just used the word front and your report says back.
Oh, sorry.
Sorry,
back.
can you explain what the front is in the back?
So the front of the hand is the palm of the hand, and
Right.
the front of the fingers are the kind of palmar aspect. The back of the hand is the back, with the back of the fingers.
And so this says over the back of the proximal phalanx of the index finger.
Yes, so that would be kind of over the back here.
Right. And that's a flapped superficial laceration. And I think you used that expression when you were describing injury 12 on your report, which related to the back of the right hand. Irregular superficial flapped laceration on the right. So here, where you say on the left, is it a similar cause?
Yes, exactly the same causes as previously discussed.
Right. And just remind the chair what that could be.
So it could be from being against a blunt surface, so potentially on the ground. Again, it's the back of the hand, so another potential defence type injury as well.
And any possible connection with handcuffs?
Potentially, depending how the handcuffs have been put on. If it's obviously a bit more distal, but if the handcuffs have been around that area and kind of taken the top layer of the skin off, that would be a possibility as well.
Right, thank you very much. Then let's move on to right leg, please. Now, right leg, there's 2 items noted here, 20 and 21, both on the shin of the right leg. One's described as a healing wound and one's described as a scabbed wound. Tell us how these differ from the other injuries that you've spoken about.
These are older injuries, so they've been there for a period of time that would have predated the incident and kind of in the lead up to death. Healing means that the wound has begun to heal. You can see the tissues around the wound change slightly as it begins to heal. So it's a way of differentiating a fresh injury from one that's been there for a longer period. Similar with scabbed wounds, you'll know yourself if you injure yourself. There's different stages of healing, and you will see a scab forming over the wound maybe after a couple of days of having the wound. So when we see something like that, we know it predates any injuries that we've seen that may be related to the death.
Thank you. And then left leg, you're 22 and 23. Over the inner aspect of the knee, there's an abrasion. Can you describe to us what the inner aspect of the knee is?
So the knee is a joint, so a kind of a ball joint, if you like. You've got the front, you've got the back. The inner aspect is the one that's going to the inner part of both legs. If you're standing up and you've got the right leg and the left leg, the inner aspect of that will be the area of the knee that's kind of facing the other leg.
Right. And when it says inner aspect of the knee, what area would that be?
That would just be the inner part of the knee, so the kind of medial side, if you like, the inner part.
And this is described as an abrasion. And
yes.
So I think you previously described that as superficial.
Yes.
What sort of mechanism can cause an abrasion on that position of the knee?
Again, like any other blunt force injury, it's impact with something, be it could be the ground, it could be an object, so anything that can cause a blunt force injury. It is an odd sight because it is quite well hidden, but again, impact with the ground would probably be at the top of the list.
Right. Could it be consistent with a baton, a strike from a baton?
And it would be unusual again because I would expect bruising rather than abrasion because batons are quite smooth, so probably not.
And 23, over the front of the upper third of the shin, an area of superficial skin loss. Tell us about this injury.
So this is just a very tiny, non-specific injury that I can't really put into the abrasion or the bruising part. You basically just see the surface of the skin that's been slightly removed, but there's no of the kind of colour that you see normally with an abrasion. So technically it probably isn't even an injury, but it's easier to kind of describe it when you're looking at these in the different parts. But it's just the kind of most minor of things, very, very non-specific.
So included, but not even really an injury as such.
Yes.
All right, thank you. Can we move on to the internal findings? You've taken us through your external findings, and this is the part of the autopsy or post-mortem where you describe the internal, these be internal injuries or findings from that.
Yes.
And let's look at head and neck first of all. And you describe an area, left frontal subgaleal hemorrhage, underlying injury number 1. Now,
Yes.
I think this morning you talked about an injury on the left forehead
Yes.
as injury number 1. Tell us what you found internally in relation to that injury.
So when you retract the scalp is basically skin with some underlying connective tissue, and we always pull it down in order to look at underneath it to see if there are any injuries there. And often underlying injuries that you will see externally, like the abrasion on the forehead, we will see underlying, it's, to all intents and purposes, it's bruising, but within the subcutaneous tissues underlying the external injury, and that's what it is. It's an area of bruising that corresponds. It would have been caused by the same thing that has caused the abrasion in the first place.
So externally it appears as an abrasion, and underlying there's also bruising that you can see.
Yes.
And it's described as hemorrhage, and you use the word bruise.
Mm-hmm.
And for members of the public who are listening to your evidence, should they understand that there's a distinction to be drawn there?
Hemorrhage and bruise we kind of use interchangeably because bruises, as I said previously, are kind of when the actual blood vessels tear and the blood leaks out into the tissues. So what you're seeing is hemorrhage. In an external bruise, the skin is not distorted, the skin is not disrupted, and that's why the skin is intact and you see the hemorrhage underneath. But whereas in the subcutaneously, because you're actually looking into the tissues, you see the hemorrhagic change. If I dissected, say if you had a bruise in the back of your hand, if I dissected that bruise, i.e. I cut into it, what I would see is hemorrhage underlying it. So it's a kind of an interchangeable term, but we tend to use hemorrhage when we're talking about the findings internally in the body, with bruising being the external description of it.
Right, thank you. And so you describe the hemorrhaging, the bruise there, and then you say the main arteries in that area appeared normal, and the brain, you give the weight. Is that a normal weight?
Yes.
And you then talk about the cerebral hemisphere showing cloudy or white discoloration and arachnoid granulations. And I'm wondering if you could explain to us what that means.
It's a completely normal finding that you can see in the brain. It doesn't mean that there's any definite pathology. In this case, I've been quite specific because there was the question of the kind of behaviour of Mr. Bio prior to the incident, and one of the causes of that can be an infection on the surface of the brain, can make you behave quite out of character. So I was very mindful of that when I was doing the description. When I looked at it, it didn't look abnormal. It didn't look obviously as if there was an infection, but I wanted to make sure that I described everything absolutely precisely. So it's a normal finding. It doesn't mean that there's any pathology there, but we try and give as much description as we possibly can.
So it was something you were conscious of, you were looking for, but you didn't find anything abnormal?
No.
And then you've indicated there that it was going to be further tested by a neuropathologist.
Yes.
Now, you've talked today about a histopathologist and yourself, forensic pathologist. Can you explain to us what the distinction is with a neuropathologist?
Neuropathologists specifically look at the brain and the spinal cord. And in any case that we do where the brain may be significant in a cause of death or significant in the case as a whole, we will always either retain the whole brain or retain parts of the brain for a neuropathologist to look at it, comment and provide us with a report that we'll then incorporate into our final post-mortem report.
So is this someone with specialist training in the brain and the pathology of the brain?
Absolutely. The same way that I did histopathology before I was specifically trained in forensic pathology, they would have done histopathology before they were specifically trained in neuropathology. So what they will do is offer opinions purely on neuropathology.
Right. But there are areas of overlap in terms of the basic training that you will all have received?
Yes, we have to have a grounding in neuropathology, we have to have a grounding in paediatric pathology, so I can, and I do in my routine cases, routinely take pieces of brain and look at it myself down the microscope. But in cases, medical legal cases, specifically double doctor cases, we would always defer to the neuropathologist for their expert opinion, because they are experts in neuropathology. I'm not an expert in neuropathology.
Thank you. And then before we move on from here, you've described bruising and hemorrhage and explained to us the distinction. Is there anything that the chair should be aware of in relation to the hemorrhaging that you saw under the skin that would assist in assessing force and the level of force required to cause these injuries?
Again, no, I don't think so. It's distinctive of blunt force injury. There weren't any underlying fractures. The skull wasn't fractured or anything like that. So it's certainly not kind of moderate or severe force that's been applied for these injuries to have been sustained.
Thank you. Then the next paragraph goes on to talk about the mouth, and you've given a detailed note of your examination of that, and you say that the tongue was normal, the pharynx was normal. You've talked about different areas being intact. Was there anything significant, as far as you were concerned, in relation to this area, the mouth, the tongue, the neck dissection at that stage, that you noted?
Just that it was normal with no evidence of injury. Which is important when we're taking it in the context of petechial hemorrhages. With different types of petechial hemorrhages or different causes of petechial hemorrhages, you may get something positive in the neck dissection, i.e. there may be injury to the muscles if there's been pressure applied around the area of the neck, or there may be injury to the throat structures, the bones and the cartilage in the throat that may be indicative of pressure or blunt force applied to the neck that may give you an indication that asphyxia has played a role in death. But in this case, the neck dissection was completely normal, so there was no injuries to the neck structures that I was worried about.
So nothing that you found that caused you any concern about that aspect?
Yes.
And you say here, no evidence of hemorrhage into the strap muscles of the neck. What area is that?
So When you move your neck from side to side, that requires the contraction and relaxation of a number of muscles that are in your neck. There are several muscles that run from kind of the area of the chin down to the clavicle, and these muscles allow you to turn from side to side, put your head up and down. If you got damage to these muscles, then you wouldn't be able to do kind of such movements. And these are they're specific muscles that attach from various structures that we always look at routinely in all of our postmortems, just to make sure there's no bruising or any damage to them.
And you say that the laryngeal skeleton was intact. What part of the skeleton is that?
So the larynx is the piece of the kind of neck that sits just behind the throat. You have the kind of back of your throat, your little thing that sits at the back of your throat that kind of wobbles sometimes, that your uvula. Just directly behind that is the pharynx, which is kind of cartilage and soft tissue. Directly below that is the larynx, and then below that you have things like your windpipe start to come from there. So these are the structures that are in your neck that can be injured in kind of specific situations that we always look at really, really closely.
Thank you. And then you say here the thyroid gland, 90 grams, appeared uniformly enlarged. I wonder, is that unusual or?
It is. It's not something we see terribly often, especially in someone young. So it's normally an indication that there is some sort of thyroid disease happening. The fact that it's uniform takes things like tumours and cancers out of the equation, and normally it means there's a diffuse problem with the thyroid gland, but often people can have that and have absolutely no symptoms and not even know that they have it, and they may present later in life with various symptoms. So it is an unusual finding.
And what sort of symptoms would someone with an enlarged thyroid gland, if they were experiencing symptoms, what would be noted by them, or what would be something that be observed?
Completely depends on the cause of the enlargement. You can get conditions where you have an overactive thyroid, so you're producing too much of thyroid hormones. So you can have things like quite a fast heart rate, you can be really hot all the time, you can be losing weight, things like that. Your metabolism is in overdrive, so everything's working too hard. Whereas people can have underactive thyroids. Both of them are causes of an enlarged thyroid, and that's the complete opposite, where you can be gaining weight and you can't explain it, or you can feel very cold all of the time. It's very difficult to get warm. Your heart rate can be a bit lower than normal. It might affect your skin and things like that. So there are all sorts of symptoms.
And was there anything that you found in your examination that would have indicated the cause of that enlarged thyroid?
No.
Thank you. And then let's move on to the next section. And I wonder if you can explain what this related to. You've described a facial dissection.
This is what we have to do sometimes in order to look for injuries underneath the skin of the face. I wouldn't do it in all of my postmortem examinations, but I do it fairly frequently, especially in double doctor examinations. Often you can have very little externally on the face, so no bruising or abrasions. But when you look underneath the skin, you can see hemorrhage, which would indicate blunt force trauma, and you can also see injuries to the facial skeleton that wouldn't be apparent from external examination. So, you
can actually get hemorrhage underneath the skin on the face without there being an external indicator of that?
Absolutely, and especially in this case with Mr. Bio's skin being so dark as well, and as I explained previously, the difficulty of seeing specific bruises would be another reason. But to be fair, even in a Caucasian person, I would have done a facial dissection in this sort of case. That would be a routine and would be best practice.
And is that because it's a double doctor postmortem, as you've said?
Yes.
And I think in your inquiry statement, without going to, I don't need to turn to that at the moment, but you talk in paragraphs 36 and 37 of your statement that where you'd been given information about him being hit with batons and maybe being face down, those were, and having dark skin, that would be a reason why you would want to carry out the facial dissection.
Absolutely. And he had facial injuries as well. He had external facial injuries. So categorically, I would 100% have had to have done a facial dissection.
And then I think at paragraph 37 of your inquiry statement, you were asked about the family perhaps wanting to carry out a viewing after the post-mortem, and your views on that, having carried out the facial dissection. Do you want to explain to the chair a little bit more about the considerations you bear in mind?
Yeah, absolutely. I mean, we, as I said previously, routinely families do not tend to see our patients until after we've done the post-mortem examination, and routinely families will come and view the body after the post-mortem examination, and it is one of the jobs of the technicians that I was speaking about previously is to reconstruct the body afterwards and basically allow the person to look exactly as they did prior to the post-mortem examination. That's certainly the gold standard that we always strive for. So I personally have never had any problems before or had anyone complaining that there was an issue with viewing the body afterwards, having done that, and it's not something that we can't do. We categorically have to do these sorts of dissections, unfortunately. But I've never heard there being a problem afterwards, having undertaken that.
Right, thank you. Can I ask you about something separate? It's understood that a quasar examination was carried out before the post-mortem began. Can you explain to people what a quasar examination is?
Yes, it's a special light examination where the body is looked at under different UV lights. It is supposed to, if there are any injuries on the body that are potentially patterned, the kind of things that we tend to think about or see is kind of foot marks. If someone's been stamped upon, and if they may have a foot mark or a shoe mark or a boot mark, something like that, then we would be asked for that to be undertaken prior to the post-mortem examination, because after you've undertaken the post-mortem examination, because you've opened tissues, it can distort anything that quasar may offer. In my experience, it's not a terribly useful procedure, but it is something that the fiscal and the police like to do if there is that sort of story, and I think in this case they quasared the body prior to.
Do you know what the results were?
Negative, because there was nothing to find, which is 9 times out of 10. I mean, to be fair, if there is a foot mark on a body, a plain photograph is perfectly reasonable for showing that, and obviously with scale. So in my experience, quasar never produces any better quality than what our photographers produce. But as far as I can remember, there wasn't anything, because if there was, then it would have been picked up at post-mortem and further looked at.
So if the findings were negative, but if they had been positive in some way, is that something you would have incorporated into your report?
Yes.
And investigated further?
Yes.
Thank you. And can we just be clear, what can cause a hemorrhage under the skin but not have any signs at all on the external body?
A blunt force impact. You can get blunt force impacts where they have had an impact with something, an object, a fist, that you don't always see something externally but can see things internally, and that's unfortunately why we have to do further internal dissections of the body to look underneath the skin to make sure that there's nothing that we're missing.
And does it make any difference to that process how quickly after that blunt force impact the person maybe dies? Or does blood stop flowing into the tissues underneath? Or
if you once you die, you obviously don't have a circulation, so the development of injuries shouldn't happen. It has been proven, and I have seen that people who have bruises sustained while they're alive after they die, there can be a change in the bruise. It can get slightly bigger, not by any huge amount. So there can be some development in injury progression after someone dies, but you can't injure a body after a person is dead. So if you've got injury underlying the tissues, it's kind of telling you the injury is likely to have been sustained before the person has lost their circulation and lost their output. Otherwise, there wouldn't be a blood supply to get to that area for the hemorrhage to occur.
So if there's hemorrhage, is that indicative of an injury during the person's life?
Yes.
And if we hear a phrase ante-mortem, would that be the sort of
Yes.
thing that means?
Uh-huh.
Thank you. Then can we look at the next section, which I think is chest on page 7. And here you say that the ribs were intact. Now tell us how you visualised the ribs and how many ribs you were able to visualise during the post-mortem.
What happens is you make an incision from kind of the lower part of the neck down to the pelvis, and you use a knife to basically pull back the tissues that are over the chest. So when you pull back those tissues, you can see the soft tissue all the way down to kind of the front of the back. And that will expose the anterior ribs, so you'll be able to see from that. You'll be able to see the clavicles, you'll be able to see the sternum, and you'll be able to see the cartilage that attaches to the sternum, and then the ribs that are coming from there. And but what we then do is we take off the sternum, so we will use very sharp scissors to take the sternum off as a kind of a triangle down either side of the chest. And when we take the sternum off, and take organs out, we can see the whole rib cage, so I can see all of the ribs in every part of them. And when we do a back dissection, we can also see the posterior aspect of the ribs as well. So I can see every part of all of the ribs. That most people have a set of 12 or 13, some with free hanging ribs, but we can see all the ribs.
And what are you looking for when you look at ribs?
I'm looking for injuries, I'm looking for fractures of the ribs, and I'm looking for any reaction to that fracture, any hemorrhage that's associated with it. Also old rib fractures as well. Not all rib fractures need to be new. There can be some that are old and healing that may give an indication of previous trauma. But the main thing that we're looking at in the rib cage is trauma.
And what signs do you look for if there's a rib fracture? What signs would you expect to see in a post-mortem?
If the fracture has happened in life or indeed during resuscitation, you would expect to see some hemorrhage associated with it, because if you fracture something, so if you break something, the mechanism that has caused that break, the force that's been required to do that, will also damage the tissues around it, so will damage the little blood vessels that are around it, and that's when the blood leaks, and that you see the hemorrhage associated with that. So often the first indicator of rib fractures is some hemorrhage that you see, and that draws your eye, and then you look at it kind of more closely to see if it's actually broken.
And you talked earlier, I think this morning, about the level of force required to cause a fracture of a rib. And I think we've got your evidence on that. Could I also ask you about what you say here about the lungs? The right was 860 grams, the left was 790 grams, and they were congested and edematous. And I wonder if you can explain to people what that means.
So they were both heavy. You would expect, like, the measurements for weights of various organs do vary from the sex of an individual, what an individual's height and weight. So there's a long charts of these sorts of things. But as a rule of thumb, I would expect the lungs to be up to maybe 450 grams, a maximum maybe up to 500. So these were very heavy lungs. And congestion and edema is basically the lungs are fluid locked. So when you look at them, when you squeeze them, lots of fluid, kind of congested blood kind of comes out of the lungs. And this finding at post-mortem is very, very non-specific. It doesn't mean anything. It doesn't tell me pathologically really anything terribly useful about the lungs in terms of cause of death. You can see it just as a terminal response if someone dies of heart disease. You see it especially prominently in people who have been resuscitated, because normally whilst they're resuscitated there may be lots of fluids being given to them intravenously. You can see it in people who have been maybe if they have drugs on board and they've been unconscious for a period of time, the lungs can get very kind of locked and congested. So it's a very, very common finding that I probably see in 90% of my postmortems. It's non-specific and it's really just a descriptive term. I suppose the more telling thing is what I'm not seeing, because I could put lots of negatives in, as in there's not pneumonia, there's not a tumour, there's not all of this, but I don't tend to do that in my postmortem reports. The fact that I haven't said it means that that's not there, because it would be described. So it's a descriptive term, but it's very non-specific.
And then you talk about the pericardial sac being normal. Where's that? So
the pericardial sac is a lining that sits around the heart. It's protection basically for the heart, and it can be injured in trauma cases, and it can also, things like if someone has a heart attack and their heart muscle ruptures, they can bleed into the pericardial sac. So we always note that if it's normal, and if it's not normal, describe why it's not normal.
And then you say the heart, 430 grams, was of normal size and configuration. Mm-hmm. What did you mean by that?
So 430 grams is a reasonable weight. It's not too heavy for what I would expect of someone of Mr. Bio's weight and size and sex. And normal size and configuration just means anatomically it was normal. Everything was where it was supposed to be. There weren't any congenital abnormalities. It looked completely how I would expect a normal heart to look.
And you say the coronary arteries, myocardium and cardiac valves were normal. And again, can you tell us what these are?
So the coronary arteries are the arteries that lie on the surface of the heart, and those are the arteries that carry the oxygenated blood to the heart. So if you have any sort of obstruction in these, for example, I was talking about previously, coronary artery disease with furring of the arteries, that would cause a lack of blood supply to the heart and potentially a heart attack. So in all of our cases, regardless of cause of death, we always look really closely at all the coronary arteries, the three main coronary arteries, because significant disease in any one of these could potentially be a cause of death. The myocardium is the heart muscle. It's just the fancy word for heart muscle, and the heart has 4 chambers. It has 2 big chambers, then 2 ventricles and 2 smaller ones in the atrium, and we always look at the slices through the heart to make sure there's no damage to the myocardium, which could be things like scarring if someone has had a previous heart attack, or there can be acute changes that may suggest a current kind of heart attack, or tumours or anything like that can happen. So that was completely normal.
And the cardiac valves? The
cardiac valves, you have 4 of those in your heart, and they basically open and close as the blood moves around the heart to the various chambers. So the blood will come back to one side of the heart and has to make its way through to the other side in order to go to the rest of the body. And these are very clever. They basically open and close when required to trap blood when it needs to be trapped, let it out when it needs to flow. And if you get And damage to any of these, for example, if you get things like valvular heart disease, you may get calcification of one of the valves where it gets very narrowed and it's not opening and closing properly. That can cause the heart to have to work really, really hard because it's trying to push blood through an enclosed space, so it has to work really, really hard. And when muscle works really, really hard, as you see if you lift weights or you work your bicep gets bigger and bigger, which is a normal and a good thing to happen. But in the heart, if your heart muscle is having to work really hard and it's getting bigger and bigger, then it's the muscle that it's being replaced with isn't good, well-functioning muscle. So the heart begins to fail, and that's when you get things like heart failure and that can kill people. So it's really important to look at the valves carefully to make sure there's no disease in those valves, which there wasn't here. They were completely normal.
So in terms of your own examination of the heart, everything was completely normal?
Yes.
The aorta was normal. Which part
Yes.
of the body is that?
So it's the biggest blood vessel in the body. It's a massive artery that runs basically the whole length of the chest into the abdomen, where lots of little arteries come off to go to various organs. So you'll, for example, have the renal arteries, which are the kidney arteries, will come off the aorta to go to the kidneys to supply oxygenated blood to the kidney. So it's the most important and largest blood vessel in the body.
And then esophagus contained fluid and the mucosa was normal. So again, is his windpipe normal?
Yes, yes. Oh, sorry, the esophagus is the gullet.
Oh, the gullet.
So it's where your food goes, which was completely normal. And we often see little bits of bilious fluid just as things come back up from the stomach, especially when people are resuscitated, because resuscitation tends to produce pressure that can bring food back up the way if there's anything in the stomach. So that's a completely normal finding and nothing to worry about.
Thank you. And then looking at abdomen, again, you rule out adhesions, you say that intestines were normal. You talk about the liver appearing congested and showed focal pale areas. Was that something of concern in relation to?
Again, no, it's a very normal finding at post-mortem, especially when people have been resuscitated. Congestion's a really common finding. It doesn't suggest any particular pathology, but it just tells me that kind of this is what I've seen, and then I can correlate that with what I'm seeing down the microscope.
And again, so the chair can read this section in due course, but really everything in the abdomen was normal, within a normal
Yes,
range?
yes.
Moving on to the musculoskeletal system, here you talk about a subcutaneous dissection undertaken on the trunk and limbs, and you give your detailed results in relation to this. I'd like to ask you about the first one of these, please. You mentioned the back earlier. We were talking about weight on the back and that type of thing. Over the left upper back, an area of subcutaneous hemorrhage extending into muscle and measuring 1 centimetre in diameter. Could you help the chair understand that entry in your report?
So what we do is we look underneath the skin on the back. So we tend to make a T-shape incision in the back and a line across the kind of lower part of the shoulders, and then we peel the skin back, looking at initially at the superficial layer of muscles, and we document any hemorrhage that may be present there. We then take back the superficial layer to the more deeper layer of the muscles of the back. The back's a very muscular part of the body. There are lots of big thick muscles there. So we tend to take the superficial layer and then look underlying that just to see if there's any hemorrhage. Well, often the back, just because of the nature of the skin and the kind of fatty tissue, similar with the abdomen, you don't necessarily have to see anything externally for there to be underlying hemorrhage into the subcutaneous tissues. So again, it's another thing that we have to do to definitively confirm or exclude if there are any blunt force injuries to the back.
Now, I think earlier today you talked about there being no external injuries on the trunk other than the one you described. And you said that the trunk included the back. And there were no injuries visible externally on the back. And here we see that you found hemorrhage subcutaneously. And I wondered if you could help the chair understand what the possible causes of that could be.
Again, the hemorrhage is blunt force in origin, so some sort of blunt force has been applied to that area for the underlying tissue to, or the little blood vessels to have broken and caused the hemorrhage. So again, the usual caveat of blunt force injury with an object, potentially if they're on the ground, and any of the other kind of parameters that can cause blunt force injuries.
And is there anything in your findings here that would assist when the chair's coming to consider, would this injury have been caused if Mr. Bai was on his front or on his back? Is there anything that could help him distinguish or assist him?
It's difficult to be certain because if he was on his front, pressure could have been applied with something to the back, but in the same vein, if he's on his back and there is something underneath, potentially that area that's irregular or blunt, then it could have happened kind of either way.
And if there's no evidence available to suggest that there was something underneath, and if there's evidence to suggest that Mr. Bio was on his front, would that be indicative of something on his back then?
Yes.
Right.
Yes.
And looking at this description, you say that this is 1 centimetre in diameter. So what type of pressure could be applied to the back that would cause an injury on the left upper back of around 1 centimetre in diameter? Again,
I mean, it could have happened with minimum force. It's just a tiny little area of hemorrhage within there, so it wouldn't have required a great deal of force, I don't think, for that to happen.
Right. And was there anything about the shape of that hemorrhage that could assist the chair? And
No, it's non-specific. There's not any kind of pattern to it.
All right, thank you. Then moving on, I also see in the musculoskeletal system of your report that you mention injuries to the shin area. And if we could move on to page 8, please. So, for example, if we see the third bullet point there, the outer middle third of the right shin, an area of subcutaneous soft tissue hemorrhage, superficially extended into the muscle and measuring 7 centimetres. And at the very final bullet point, again, an injury to the left shin area. I'm wondering if you can help the chair understand what could have caused this type of injury, this type of hemorrhage in that area.
It's blunt force in origin again, so a blunt force impact with something. For example, batons, if those have been in use, something like that would be kind of classical of causing, because there's a reasonable amount of hemorrhage on both sides, the kind of right more than the left. So potentially anything that's blunt force that could have been applied to that area.
So if there's evidence available to the chair about baton strikes to the legs, is that the type of thing that would be consistent with that injury?
Yes.
We've also heard evidence about leg restraints being used and applied. Is that the type of thing? These are soft leg restraints.
It's probably less likely, but it's still possible, especially if there's some movement and they've been put on with a degree of movement against them.
Right.
But it's possible.
And in terms of the size and shape of these injuries, is there anything that could assist the chair and help understand or distinguish between those two possibilities of baton or leg restraints?
I think given the size, particularly on the right, it's probably more likely to be baton than restraints, unless there's been a massive movement of the restraints up and down the leg, kind of with pressure applied to them. It's probably more likely batons.
Right, thank you. And then can we move on, please? We see that You say no evidence of fracture or deformity, and then further investigations. Now, earlier today you talked about the different investigations that you would instruct specialists to carry out. You mentioned a number of these. See them listed here: histology, neuropathology, toxicology, bacteriology and virology. And you've given some brief descriptions of the nature of those investigations. Can I just ask about the bacteriology and the virology, please? I don't think they've been mentioned so far in your evidence. Tell us about bacteriology.
So bacteriology are samples that are sent that look for bacteria, in that there are certain bacteria that can kind of overtake the body and be responsible in causing someone's death. So we will often take either swabs or pieces of tissue at the time of post-mortem. They are sent to the microbiology lab. They will be grown or incubated to see if they grow any specific bacterias, and they will then give us a report that we will then incorporate into our post-mortem reports, and if anything is grown, make a decision as to whether it's important or not. The problem with bacteriology is after someone dies, they automatically begin producing bacteria. As the body begins to decompose almost immediately, so bacteria will be produced, so it can be very difficult to differentiate ante-mortem from post-mortem bacteria, and that's why it's very much correlated with what you're finding at the post-mortem. For example, if I had a case with a pneumonia and I sent a bacteriology sample that confirmed a bacteria that's associated with pneumonia, then I would be reasonably happy that I have a causative bacteria. So there has to be some sort of correlation with what you're finding at post-mortem, because I could send off a bacteriology on someone who I have absolutely no suspicion at all of any sort of infection, and I guarantee it'll come back with 4 or 5 different bacteria, and a lot of that is post-mortem contamination. Our body in itself are covered in bacteria, commensal bacteria, which is healthy bacteria. If I swabbed anybody in here's mouth at the moment, I would get several bacteria, but that's fine because it's normal and it's not doing you any harm. And the problem at post-mortem is we will grow that bacteria, but we have to work out if it's important or if it isn't. And 9 times out of 10 it tends to not be important because we can't be sure it's definitely post-mortem.
So how common in your experience is post-mortem contamination?
It's 100% of cases there will be a degree of post-mortem contamination because bugs are being produced at post-mortem.
And because people have bugs on them.
Exactly, yeah.
And I think I won't take you to your inquiry statement, but I understand you've provided further details of these investigations at paragraphs 42 to 48, and you've given a fuller explanation of each of these different types of investigation. Yes. The Chair can consider that in due course. Can I ask a question? We've been touching on what's post-mortem. We know that there were samples taken at the hospital of blood and urine, and we know that you took post-mortem samples.
Yeah.
And we're trying to understand what the difference is in terms of the samples taken during the hospital when they were trying to resuscitate Mr. Bio, and what you would class as your post-mortem samples. And can you explain what the distinction is and the importance of the difference between them?
So when someone is resuscitated, they tend to put various cannulas and things in, and they also tend to take a set of bloods that will be sent to the lab to give them some sort of information as to maybe a reason that the person is so unwell. And those are known as hospital blood samples, and we will always try and get a hold of those samples because they are much easier to work with and give much clearer and more exact information than our post-mortem samples. The problem is that they're often destroyed quite quickly after a person dies, but we will always instruct the police, to be fair, they know now, ASAP, get a hold of those samples if you possibly can. And they would be I suppose our gold standard, if you like, in the lab. If there tends to be limited samples because they're very tiny amounts, but I would always kind of try and prioritise what drugs I might be most interested in if I do have limited samples, and I would take my results primarily from the hospital samples, because post-mortem samples, as much as we try, a lot of drugs redistribute. So once someone dies, they spread their way through the tissues, they spread their way through blood, and we often get artificially high levels at post-mortem. There are a lot of things that are produced after death, things like alcohol. You can have no alcohol in your system at all when you die, and I could do a post-mortem and do post-mortem toxicology, and you would have a reasonable amount of alcohol, because it is one of the ways that the body begins to decompose. It starts to produce alcohol, so it's naturally produced after death. And there are other drugs that break down much quicker, and the post-mortem redistributions, there's lots of reasons that the post-mortem samples that we use are not optimum, and can often limit what we can say in terms of how we would conclude how important these drugs have been, depending on the drug and depending on the post-mortem interval and depending on the degree of decomposition. So there's lots of other factors, but ideally if we can have the blood samples that are taken around the time of death or in the kind of resuscitation period, that's ideal to look at from a post-mortem point of view.
And would it be reasonable to say that they give a more accurate indication of what was in the blood or the urine?
Absolutely, because they haven't,
better than the post-mortem results.
Definitely, because they haven't begun to decompose, they haven't begun to break down, so they would be much more accurate.
Right. And would that be the position even if the person died on one day and the following day there's a post-mortem? So even if it's a 24-hour period or more than 24 hours?
I still would take the hospital bloods over the post-mortem bloods. Right. Yeah, even a day. I mean, a day is good, to be fair, that's reasonable, and the post-mortem samples may not be too distorted, but I still would ideally go back and reference the hospital samples.
Thank you. And then, as well as these further investigations which you've listed here, am I correct in saying that there were also X-rays and a CT scan carried out?
Yes, so after the case, we had a discussion at post-mortem you can look at pretty much everything, but what you can't see without really detailed evisceration of the patient, which is not something we want to do. We don't want to do anything else to the body if we can possibly avoid it. So what we have are tools like X-ray and CT. So our main concern, kind of following the post-mortem, was that we hadn't been able to have a look at the long bones, so the leg bones and the arm bones. Everything else we could obviously see, the ribs, the skull. So a plain X-ray would give us that information. So that was organised to happen following a discussion after the post-mortem examination, or the days following, I can't remember the timescale. So that was undertaken, and the body was transferred up to Edinburgh Royal for that, because that's where our facilities are for that. We don't have those facilities at the City Mortuary. Those scans were then looked at by a radiologist. We have a dedicated forensic radiologist who does all of our scans and reports all of our scans, but they couldn't visualise the cervical spine, so they couldn't visualise the neck basically from the top of the chin to kind of the top of the chest properly. And given the kind of description of them being on the ground and things, I wanted a really good note that there wasn't anything in the cervical spine that I needed to then go back and look at. So the decision was made to CT the body for further examination, because that gives much better pictures of the cervical spine. So the body was transferred back up for a CT, so we got a full body CT that then visualised the cervical spine. So there was 2 lots of imaging done after the post-mortem.
And we'll come on to that in a moment, but so that was 2 further pieces of investigation carried out. And just to complete the consideration of your report, we can move further down the page. You then detail productions for the police. You've talked about Perk and DC Grady being there to take productions. And then your opinion as to cause of death, you've given there, and you've explained earlier, 1A, unascertained pending investigations.
Yes.
Thank you. I'd like to move on to your final report, please. And this is, let me just see the number.
Moving on to that, although it's slightly before 3 o'clock, it might be better just to take a 15-minute break now.
Yes, thank you very much.
Very well. Graham.
Thank you. We were just about to turn to your final report, and we'll get that on the screen, PERC 01445. And we'll look at the first page, and we'll see at the top final report. Now, this wasn't issued until the 18th of June 2015. So is this issued after you've received the results of the various investigations that you've described to us already? And if we move down that page, we'll see that the medical cause of death, having initially been described as unascertained, pending those investigations, we now see it is given as sudden death in a man intoxicated by MDMA, which is called ecstasy, and alpha PVP whilst being restrained.
Yes.
And so that was certified by you as the medical cause of death. And that was after all of the results that you'd considered.
Yes.
Now, if I tell you that we've not heard evidence from this witness, but the chair has a statement available to him from a professor of cardiac pathology, a Mary Shepherd, who says effectively that everyone dies of a cardiac arrhythmia at some point because effectively your heart stops beating, and that is what kills effectively everybody.
Yes.
So where it says sudden death, would you agree with Professor of Cardiac Pathology Mary Shepherd that effectively that is when your heart stops beating?
Yes.
Thank you. And you've now introduced as part of the cause of death the MDMA or ecstasy, which was one of the results from the toxicology report that you received.
Yes.
That was found in the blood sample that had been sent.
Yes.
We'll look at that in more detail in a moment. And also a drug called alpha PVP was found.
Yes.
And you said whilst being restrained.
Yes.
And that was the circumstances as you understood them at the point at which Mr. Bio became unconscious, stopped breathing.
Yes.
Thank you. Let's move on to page 3, first of all, because I think on page 2, essentially the information on that page is the same as your initial report.
Yes.
And on page 3, we see some new additional information that's been added in. So is this effectively this report a revisal of the initial work that you've already done in the initial provisional report after the post-mortem?
Yes.
So you're building on that in light of the new information you have.
Yes.
And we see that the second paragraph there were reports that both PAVA and CS gas were deployed by police officers.
Yes.
So you've been given further information and you've now incorporated the extra background information into this report.
Yes.
And then, without going through pages 3 and 4 and on to page 5 in detail, do we see that you've simply updated and summarised the additional information that you've been given, and that included additional statements and additional information about the circumstances of Mr. Bio's death.
Yes.
Thank you. And then we move on to page 5, please, and we see external findings. And again, at the bottom of that page, we see the same content in this report as we did in the initial report.
Yes.
And that remains the position, I think, until page 9 of this report. Effectively, it's building on your initial provisional assessment.
Yes.
So if we can go to page 9, please. Thank you. And we see just above chest, it says the cervical spine was intact. That's a new entry. And at the chest, towards the bottom of that page, you then expand and say, following the CT examination.
Yes.
And is this where you expand on that additional radiological assessment of the skeleton and the CT scan?
Yes.
And what we see there is it says that the CT examination was undertaken after the post-mortem. The 7th cervical vertebrae and first and second ribs were re-examined. Can you tell us about this, the detail that you've put here into your report?
So from the CT examination, there were things on the seventh cervical vertebrae on the left first and second ribs that were flagged up as potentially being injuries. So we went back to the body to visualise those areas to determine if it was artefactual, secondary to the post-mortem, or were there indeed injuries there.
Right. Can you, when you say visualised, you just mean have a look?
Yes, have a look.
And when you talk about artefacts or artefactual, can you explain to people what that means?
When the post-mortem is undertaken, we obviously do various things to the body using things like saws and knives, so we can introduce injuries ourselves during that time. And because the CT was undertaken afterwards, it's very difficult for the radiologist to know exactly what these findings may correlate to. Hence why the optimum way of managing that is to go back to the body and actually visualise what they're seeing, and then from that we can work out how significant they may or may not be.
Would the radiologist have as much information about circumstances as you would?
Not necessarily, no.
So you then go on to say vertical incised wounds were seen, and you describe where. Can you tell us what this is about?
So there's vertical incised wounds through the front of the cervical vertebrae. The neck has 7 vertebrae in it. They're basically the neck bones that the spinal cord runs through. And when we did the post-mortem, we, in addition to taking the brain for the neuropathologist to look at, we also took the cervical spine. So that requires using a saw internally to disrupt the side of the bones of the neck in order to take off the cervical spine and find the cord, which is what controls your movement, controls your breathing. So what's been seen there is when we've gone back, what we've seen is the marks that we've made having done that at the time of the post-mortem, but it's impossible for the radiologist to differentiate if that's real or if that's been done during the post-mortem, hence why we go back and have a look and clarify exactly what the cause would have been. So we were quite happy that what she was seeing in the cervical vertebrae was indeed artefactual, created by us, and not something that was a true injury.
Thank you. And then it goes on at the bottom of that page to say soft tissue overlying the front of the posterior part of the left first and second ribs. I wonder if you could explain this part of your report.
So the first and second ribs are kind of at the top of the chest. It's almost kind of semicircular as they sit in the kind of top of the rib cage. So they're not parts of the ribs that are obviously visually seen at the time of the post-mortem, because they're quite hidden behind, unless obvious hemorrhages surrounding them extending into other parts of the tissue. It's not something that we would visualise at the time of the post-mortem routinely. So what we've had to do there is remove part of the rib to see what was going on behind, and what at the area that the radiologist has flagged up. And from that, when we looked at it in the PM room, there was some soft tissue changes, kind of discolour of the soft tissue, which could have been hemorrhage, which may indicate something fresh going on. And there was a possible fracture through that first rib. We were happy that what she was seeing in the second rib wasn't a fracture. There was nothing there that we could see that we were worried about. But the first rib looked as if there was a possible fracture with some potential soft tissue reaction. The other problem is that after the post-mortem, even though the body is refrigerated, specifically internally, things still begin to break down even in the lower temperatures, so you still begin to get changes in the colours of the tissues and from gas production and things. So it can be really difficult to differentiate what's true ante-mortem from what's true post-mortem, just kind of naked eye.
Difficult to distinguish ante-mortem hemorrhage from post-mortem hemorrhage.
From post-mortem changes because of the
Post-mortem
coloration of the tissue.
Right. And how long had there been between your first examination, your first post-mortem, and this second visualisation?
I think there was at least a week or so. I think I have said that in my statement if you want me to try and find it.
No,
But
that's
there,
fine.
there
But
was
it
a
was
reasonable time,
there was a reasonable time.
gap there. We'd already had the examination of the skeletal survey initially, and then the CT after that, and then the CT being reported to giving us the information for us to then go back to the mortuary. So there was a significant time lapse between the initial post-mortem and going back to have a look.
And that period, during that period, the body remains in a refrigerated environment, but you cannot prevent deterioration taking place.
No,
decomposition.
Even especially internally, because the tissues internally are breaking down continually, even in a refrigerated environment. So yeah, you're going to get some deterioration, and there's nothing you can. Again, I spoke about it previously, freezing, but we couldn't do that until we had all the information that we required, because that would have been detrimental to the examination as well. So it's impossible to stop some sort of breakdown happening.
In the absence of freezing, which wasn't possible, you can't prevent that natural event taking place, the decomposition.
Unfortunately not, no.
Right. And, I'm grateful to my learner junior. I think in paragraph 65 of your inquiry statement, you say the CT scan was carried out on the 28th of May.
Okay.
Right.
Yeah.
And so if we could just look at that. You've described it's in the left first rib. You've also looked at the left second rib. That must be close to the first rib.
Yes. Uh-huh.
But you didn't see any evidence of injury to the left second rib at all?
No.
And when you say no evidence of injury, does that include no evidence of signs of hemorrhage or soft tissue injury?
Yes.
Yeah. So the signs you saw only related to the first rib?
Yes.
And then going back to, we'll come back to the issue with the rib in a moment. Going back to your report, we see you go back to abdomen, and then you return to musculoskeletal system, and those are exactly the same as your original report.
Yes.
And then at the bottom of page 10, we see further investigations, and again here, radiology. Following the post-mortem examination, a skeletal survey and CT examination was undertaken. And then on to page 11, you continue to repeat your original views on the cause of death. And then we move on to toxicology, so we'll have to come down that page slightly. And here is where you describe the results of the toxicology. Mm-hmm. Now, I think in the hard copy of this report, you've added in the results at the back of the report, or we see copies of those, but you've incorporated them here. And I wonder if you could just summarise what was the results of the toxicology, please.
The toxicology showed in hospital blood and in post-mortem blood two different drugs, the alpha PVP and the MDMA, or ecstasy is how they kind of would normally be known. We also looked for a variety of other drugs. We screened for probably up to at least 50 other drugs in terms of illicit drugs, things like cocaine, heroin, to prescribed drugs, things like paracetamol. So we look for a variety of other drugs in all of the toxicology, and what is reported is what's positively seen, and that's what's kind of stated in the report, what the toxicologists have found, but there will be a variety of drugs that have been screened for and have not been found on the sampling.
And you've given the details of the concentrations, if I can use that word.
Mm-hmm.
We'll hear evidence later in relation to the drugs from a toxicologist,
Mm-hmm.
but this was sufficient information for you to complete your examination, complete
Yes.
your post-mortem report.
Yes.
And moving on to page 12, please, following on, do you see under the results, all other analyses were negative? And is that the other tests that would have been carried out at the time?
Exactly, yes.
And then you talk about a urine sample was sent to King's College, London,
Yes.
and analysed for urinary androgens and synthetic anabolic steroids. And this showed the presence of nandrolone and metabolites, consistent with the recent administration of the anabolic steroid nandrolone.
Yes.
Can you explain to us what that finding
Yeah.
was?
I was given the information that Mr. Bio had a history of taking steroids, and in any case, if I'm giving that information, I will always try and get the samples analysed for that specific drug. It can only be looked for in urine, and it's not done by our labs in Scotland. It has to be sent down to London to a specialist lab. So that's why specifically urine was sent, and it was sent to London.
And it says, sorry, I've lost it. Consistent with the recent administration of the steroid nandrolone.
Yes.
Can you explain what you meant by recent administration?
In the previous kind of few days to a week or so, steroid use is not something that we see as acutely causing people to die. We see it as more of a confirmation that they've been taking it. What we can see is long-term effects of it, chronic changes where we can get heart damage, which we didn't see in this case. But the only real reason for doing it in this case was to confirm or exclude if he had it in his system or had taken it recently.
Right. And we see the final paragraph of this section. There had been items seized from Mr. Bio's house, and they were also analysed, tablets were analysed to see if there were any controlled drugs under the Misuse of Drugs Act 1971, and the majority had a negative result. On one bottle contained tablets, the presence of caffeine was indicated, and 2 boxes of tablets were omeprazole and were packaged appropriately. And tell us what that meant.
This was extra information that we were given. We often, if there are medications or tablets found at a scene, we want to know what they are, because we need to check for them in the patient's toxicology. So this was just further information that was given to us so that I could then, because I wouldn't normally check toxicology for caffeine. This is the one and only case I've ever checked toxicology for caffeine. It's not a routine test that we do, because it doesn't tend to kill people. People don't tend to die from caffeine toxicity, so it's not on our routine screens. So we need to know these things, because they won't just be picked up on toxicology by the routine drugs that they normally check for. So I then have to speak to the toxicologist just to make sure that's added in, make sure they have a method of undertaking that. Often, again, it has to be sent to other labs for it to be undertaken, because certain labs won't have methods for doing it. But I think in this case our lab was able to do it, but wouldn't have been able to do it without the information that it was potentially had been taken. And sorry, just going back to the nandrolone, what I should also said, that the reason it's kind of recently is because it's found in urine. When we find drugs in blood at specific levels, we can give an indication as to how recently they may have been taken. But when something is found in urine, I have no idea if it's in his blood or if it's been metabolised into the urine. It can also remain in the urine for a reasonable period of time. So I can say that there has been relatively recent use of the drug, but I can't say when exactly that would be because it's been metabolised and does hang around for a while afterwards.
So you can't be specific about the timescale or how recent that has
No.
been. Right. And we also see from this section, actually it's on page 11, that the blood samples and the urine samples were analysed for alcohol, and you've indicated that other results were negative. Now, we may have heard some evidence that was an indication that alcohol had been drunk by Mr. Bio, and I wondered if you could help the chair understand how it is that someone who has perhaps drunk alcohol could have a negative result in his blood and urine.
An explanation would be that it's been metabolised. So he has metabolised out of his blood and it's been metabolised out of the urine. It would be strange if he had recently consumed the alcohol within the kind of hours in the lead up to his death. But alcohol is metabolised reasonably quickly. The toxicologist, to be fair, would be able to give you more information in this. I'm not an expert in toxicology and in drug metabolism, but it also depends on what's in a person's stomach. Different types of food will increase or decrease metabolism, and so there's all sorts of different parameters. But it is unusual if someone's consumed alcohol within a reasonable, limited period of time before they've died that we're not even seeing it in urine. Because normally not seeing it in blood is relatively common because it's metabolised very quickly, but then not to see it in blood means it's been metabolised in urine means it's maybe been metabolised out of the urine as well.
Well, we'll maybe hear more evidence from the toxicologist.
They
about
would be
this.
the best to ask about exact timings as to what you would expect depending on different situations.
Thank you. And then we see that you detail microbiology and you talk about different swabs and tissue, and it appears from this section of your report, which is a new section, that there were some findings, and I'd rather you try to pronounce these than me if you don't mind. So can you tell us a little bit about the significance of these findings, please?
So this again goes back to the taking it in context with the whole case, and the fact that if you submit a sample of something to microbiology post-mortem, you will grow something, even if it's nothing to do with being present in life. And I think that's what we've found here. We've found some bacteria on the swab of the brain and on the brain tissue that can be significant in specific circumstances. I tend to speak to microbiology with these sorts of results to get their opinion, because they are the people that the clinical doctors will speak to when they're finding specific bacteria to see how it affects patients and how it should be treated. So I do tend to speak to microbiologists when I have results that I might not even understand. But in this case, the bugs that have been grown, you can see in cases of people that have maybe had neurosurgical interventions, so they've maybe had some sort of brain surgery where the bugs can be introduced at the time of surgery. But with the bugs that are present here, the fact that there's nothing like that in the past medical history and there's no open wounds or anything makes it highly unlikely that these bugs are significant. I was talking about context, and the context of this case is that you have to take this in conjunction with the neuropathology. Firstly, what I was saying grossly, what Professor Smith saw grossly, which wasn't very much, and
He's
the fact,
the neuropathologist.
Yes, the neuropathologist, and the fact that looking at the brain down the microscope, there was no evidence of inflammation, there was no evidence of infection, so there was absolutely nothing to suggest that any of these bacteria were critical or crucial in involving the death. I think they're post-mortem contaminants, so we excluded them as being significant.
So you discussed this with the microbiologist.
Yes.
Are they more specialist in this area than you yourself?
Their specialty is microbiology, so they are the people who interpret, mostly in life, to be fair, and there's not many microbiologists have a lot of post-mortem experience, but they are the doctors who in life will look at what bacteria has been produced, how it's affecting a patient and how you treat it. They decide on antibiotic kind of regimes and things. So they know specific bacteria are caused by specific things or are produced in certain parts of the body much more than I would. So it's a two-way conversation, to be fair, because they don't have specific post-mortem experience, but they can certainly help in the guidance as to what you would expect to patients in life, and I can try and correlate that with what I have in someone who's obviously dead.
And where it says here results were very likely from post-mortem contamination, was that something that you and the microbiologist agreed on?
Yes.
And then I think in your inquiry statement, and I won't take you to that in detail, but at paragraphs 88 and 89, you talk about this entry in your report. And again, you say you're supported in that fact by neuropathology did not find any infection or inflammation in the brain.
Yes.
And so there was nothing that the neuropathologist found that would have caused you concern there was a brain infection.
Yes.
And nothing that you were able to see in your postmortem that would have given you cause for concern that there had been some sort of brain infection.
Yes.
Right. And the microbiologist agreed.
Yes.
Can we look at virology on page 13, please? And it says here a brain swab was submitted for virological examination and the results are as follows, and they all appear to be negative. Can you tell us how does this differ from the microbiology tests?
These tests are looking for specific viruses rather than bacteria. So microbiology is bacteria and virology is looking for viruses. This is not something I commonly would do in postmortems, and the main reason for doing it in this case was because of Mr. Bio's behaviour prior to the incident. As I mentioned previously, there are specific brain infections that are caused by certain viruses that can make people act out of character and completely not be themselves. And that the main reason for doing this was to exclude that as being a cause of such behaviour. And again, you would tend to see something on the surface of the brain, although less so for a virus than bacteria. You're much more likely to see something grossly. Viruses can present where you see very little on the brain and you only know it's there because you've tested for it. Grossly, but histologically, i.e. down the microscope, you would see something if there was a virus there that had caused problems. And obviously Professor Smith hadn't seen that either.
So there was nothing in terms of the virology or the histopathology, nothing that you saw, and it appears that there was no virus which caused any difficulties.
Yes, that's correct.
Thank you. And then let's look at histology. Again, you've gone through various organs, the brain, the heart, the lung, the liver. Any abnormalities or concerns in relation to your investigations in this regard?
No. There was nothing certainly suggestive in the histology that would have been related to causing death.
So nothing in histology at all. Can I ask you particularly about the heart? You've talked in your inquiry statement about the heart and the investigations between paragraphs 55 and 58. Mm-hmm. You've told us earlier today, as far as you could see in your examination, the heart was normal, mm-hmm. and the surrounding areas were normal, the arteries were normal. You clearly carried out further samples and looked at these different areas, SA node, AV node, ventricular mapping. I wonder if you could explain to the chair these additional tests that you carried out in relation to the heart?
So the SA node and the AV node, the heart is kind of a big ball of electricity, if you like. There's a conduction system that passes through the heart through nerve channels that goes from one side of the heart to the other and then goes diffusely through the big kind of chunky vessels, and it basically regulates the beating of the heart. If there is any issue with that system, at any point you can get disruption of that beating of the heart, and you can get what we call as a cardiac arrhythmia, or you get various types of cardiac arrhythmias, but the ones that we worry about are the ones that are not compatible with life, the ones that mean that the heart is so out of sync with itself that it can't beat properly, which means it can't send oxygenated blood to the rest of the body, and also that it puts it at a greater risk of just stopping and the heart stopping altogether. So the SA node and the AV node are two parts of this conduction system, but they're little stations where things are exaggerated. So it gets here and kind of starts again, goes down the nerve pathways, gets to the next node and kind of starts again, and then goes down further nerve pathways. And what you can see sometimes, especially in people with congenital problems with their heart or congenital problems with their conduction system, you can see scarring in these systems. So in these sorts of cases where I want to get as much information about the heart as possible, I will take this conduction system. I can take it. I know where it is in the heart, I know which parts of the heart it's in, so I can take that and I can look at it down the microscope to see if microscopically there's any scarring, which there wasn't. And the ventricular mapping is to give me as much information about the ventricles as possible. The heart is a kind of a globular structure. As I've said previously, you have these two big ventricles, the right ventricle and the left ventricle, make up the majority of the heart muscle. They're the parts that do most of the beating, in particular the left ventricle. And with ventricular mapping, what we do is we slice from the base or the apex of the heart right up to where the valves are, there at the top of the heart. And we can lay that out, and we can basically look at every level of those ventricles right up to the heart valves. And if I take what's called a mid-ventricular slice, it's the optimum part of these ventricles. And if I look at every part of that down the microscope, there is very little that's going to be happening in other parts of that heart that I'm going to miss, because I'm covering every part of the circulation that's in the heart. So the three main coronary arteries will provide blood to different parts of the heart. And if I'm looking at that big part of the heart, I can see if there's any damage, kind of chronic damage or acute damage, and it's a good correlation with the rest of the heart, because I can't put through every part of the heart. That would be thousands of slides, but this is a method that we've determined that gives us a huge amount of information about the heart, and that's the mid-ventricular slice. And by mapping, I can put it back together again. Basically, I have a sheet with a picture of the ventricle, and the lab technicians will block that out for me. So when I'm looking at it down the microscope, I could basically put it back together as a jigsaw and see exactly where in that ventricle I have looked at. So if there is an issue in one part of it, I can say it's in this particular part in my report. So, and then I can maybe correlate that to a particular blood vessel or a particular scenario. So it's a way of getting as much information about the heart as possible.
And this method that you've described, is that a method that you used when you were looking at the heart of Mr. Weil?
It is, yeah.
And so you did all of that mapping and assessment. And what were your views in relation to the heart?
It was completely normal.
And I think in paragraph 56 of your inquiry statement, you say, I wanted to make sure that there was no heart disease that would have played any role in his death. And how satisfied were you, having carried out this method, that there was no heart disease that had played played any role in his death?
Very satisfied. And all of the sections were also reviewed by every forensic pathologist in my department, so another 5 forensic pathologists also looked. We tend to cross-reference with our cases, especially our more difficult cases. So everyone looked at this heart in great detail, and we were all of the same opinion that none of us could see anything that was at all worrying for heart disease.
And was there anyone objecting to that or putting forward a different view in your own department?
No.
Right. And as far as you know, if anyone had seen anything that caused concern, would they have felt able to raise that with you?
No, absolutely. We do it all the time.
Can you help the chair understand, in your own practice, how many times you've carried out this method, this assessment?
Very frequently. I do it in a lot of my natural deaths as well, especially for people who don't have a history of heart disease, but I'm finding heart disease. So I probably do it at least once or twice a week in cases, so I do it very frequently.
And is that throughout your time as a consultant forensic pathologist?
Yes.
In both double doctor postmortems, but also postmortems where there's just one doctor?
Yeah, and the vast majority of cases will be one doctor postmortems. Most double doctor postmortems don't require such kind of intricate looking at the heart. So the vast majority will be our one doctor postmortems that I would do this sort of procedure.
Right, thank you. And then you've also come back to the other organs. I think no significant abnormalities found or issues. Can I ask you about the top of page 14, please? And you'll see that it says left first rib, a fracture is confirmed, but there is no evidence of obvious associated hemorrhage, and a special stain for iron is negative. I wonder if you could explain this to the chair.
So when I've gone back to look at the rib, I've found the fracture grossly. I've taken that rib from the body, I've taken the fracture area from the body, and I've then dissected that in order for that fracture to be looked at down the microscope, because I want to make sure it's a fresh fracture, there's no evidence of healing, and also to look at any reaction that might be associated with it. So in all fractures down the microscope, you can see if there's soft tissue hemorrhage. You see red blood cells. It can be difficult sometimes, especially if the tissue is quite broken down and kind of decomposed. And what we have in those sorts of situations are special stains that we can use that shows up. Stains for iron, so when blood kind of breaks out, there's iron in the blood, and when that kind of leaks into the soft tissues, it lights up as a kind of a bright blue colour if you see it down the microscope. But again, in post-mortem tissue, often these special stains don't work as well because the tissue, the kind of makeup of the tissue has been disrupted, and the proteins in the tissue have been disrupted or are dead, and that's what the lab is looking for the stain to react with. So it's not always, just because it's negative doesn't necessarily mean it's negative in a post-mortem setting, I suppose is what I'm trying to say. But what I was trying to say, to see if there was any definite fresh hemorrhage there, which I couldn't confirm.
So you couldn't confirm that there was fresh hemorrhage.
Mm-hmm.
But you're aware, as I understand it, that other evidence will be available to the chair.
Mm-hmm.
He has an inquiry statement at the moment. We've not heard from a person called Professor Fremont,
Mm-hmm.
who's an osteoarticular pathologist.
Yes.
And we'll hear evidence from him later in this hearing, as I understand it.
Mm-hmm.
Would it be fair to say that he has a specialism that is in bones and fractures that perhaps will be able to assist the chair more?
Absolutely.
Would you
Yes.
defer to him?
Absolutely, yes.
Well, we'll maybe touch on this slightly later, but if we hear from Professor Fremont that the special stains which he instructed show that it was a fresh fracture. Is that something you would defer to?
Yes.
And also in relation to the timing of that?
Yes.
Thank you. Looking again, continuing to look at page 14, do we then see that you've detailed here the radiology, you've given the dates of the x-ray, you've commented on decomposition, and you've commented on the CT scan, which is the 28th of May. So we have those details here in your report. And you talk about direct visualization was advised in relation to that rib fracture. Underneath that you say, there is well-defined linear lucency in the medial posterior aspect of the left first rib. I wonder if you could explain that paragraph, please.
So that's come directly from the radiology report. So that's how the radiologist has described what they've seen. It's radiology speak. To be honest, it's not pathology speak. What it tells me is that she's seen something there that I need to look at. So I don't think it's not being specific as to what it may be, but it's giving me an area to go back and look at.
So this was the radiologist advising you to carry out direct visualization, have another look yourself.
Yes.
And where it said there is a similar but less marked appearance of the second left rib in the same position, what did that mean?
So what she saw something in both the first rib and the second rib, and I have then advised that direct visualization should be used. So I have then gone back to look at both of those areas to see what I can see grossly, and I couldn't see anything of worry in the second rib.
Thank you. And then we come on to neuropathology. And taking this short, we see neuropathological examination has demonstrated changes consistent with evolving global ischemic brain injury. There's no evidence of any significant traumatic injury to the brain and no infectious disease. No natural disease is noted to account for death. The changes all appear secondary to cardiac arrest with resuscitation and a short survival period. I wonder if you could explain that, because evolving global ischemic brain injury sounds dramatic to people who are listening.
What has happened is when Mr. Bayou has gone into cardiac arrest, there is a period of the brain being starved of oxygen and nutrients. He's had rigorous resuscitation over a fairly significant long period of time, and so during that time they have been delivering oxygen to the brain to a certain degree, certainly not would normally happen if he was breathing normally for himself, but they've obviously been doing very successful resuscitation to keep a degree of oxygen going to the brain. But even with that happening, the brain cells are beginning to die off because they're beginning to become ischemic and hypoxic because there's not an adequate amount of oxygen or nutrition getting to the brain. If, for example, the vast majority of people we see who have a cardiac arrest, who are maybe resuscitated in their house for a period, or for a short period of time and are pronounced dead in their house, we won't see any changes in their brain because it takes a period of time of some sort of perfusion for those changes to continue to develop and to happen, for us to see them down the microscope. So because in this case the resuscitation has gone on over a significant period of time, those changes have had a chance to develop. It doesn't mean that they were ever going to be able to bring him back or get a pulse back or get a blood pressure back. It just means that reasonably good resuscitation has been happening to try and perfuse the brain, but because the brain has been starved for oxygen for a period of time, the damage is done and there's no kind of coming back from that, but there is a period of time for those changes to develop in the brain for us to see them down the microscope.
But this is a part of the process of his death,
rather
than some other condition that applied.
No, absolutely. It's just the acute changes that are seen because of the hypoxia and resuscitation. It's got nothing to do with anything else.
Right, thank you. Before I move on to page 15 of your final report, I should have asked you to look at something and I forgot. So can I ask you to look at WIT 00045? And this is an image which shows should show the first rib. Here we are. I think you've been shown this and asked to comment. And just for the purposes of identifying where the first rib is, you've obviously given your explanation. And can we see on the top left, there's an area highlighted in red. And so what would be the left first rib? I should say you should be able to touch the screen, and a circle will appear if you find that easier, or you can tell us just from your.
So obviously it's a skeleton,
Yes.
the various bones in the body, so it's kind of facing. So the left and right is going to be kind of turned around, if you like. So this will be the left side.
So
here,
it's the person's left,
you.
effectively.
Yeah.
So as the person would experience left, it would be their left.
Yes.
And that's where you've identified, that's the left first rib.
Yes.
And you described in your evidence earlier that was quite an area that was protected by certain tissues of some description.
Can you deep into the shoulder girdle? So there's lots of muscles surrounding it. From the shoulder has quite a lot of muscles. It obviously has a lot of movements that it has to do, so it needs a reasonable amount of control. So there are a lot of big kind of muscles around that area that protects that part of the rib.
Right. So looking first of all at the image on the top right, that's skeletal. Are you able to see the first left rib in that image?
That's on the.
Is that on the right?
The right hand side.
Right. So it'd be opposite that.
It'd be the opposite that. Yeah, it doesn't look as if it's on that one. You've got that's the sternum that I was talking about here. And the other rib would normally come from this joint here.
Right.
And then go all the way around to articulate with the first thoracic vertebra.
And we see on what would be the right first rib on this image, there's a bone that goes underneath. Is another bone? Is that the clavicle?
So the clavicle goes over. The clavicle is it's probably easier to look at it on here. See the one on here that's almost translucent?
Yes.
That's the clavicle. And it kind of sits, you can see it where it's more solidified on the top right hand picture. It kind of runs over the first rib.
So from the neck or the sternum area to the shoulder?
Yeah, so it goes over the top of it.
Horizontally?
Yeah.
And the first rib goes underneath that?
Yeah, so the first rib will start from where I've got number 4 here. That's the first rib going all the way around there.
Right.
So it's kind of like a horseshoe that sits to the side of the neck.
Perhaps we could remove the number 4 and see if we can get a line instead. Although I think it's clear to everyone, but if we remove 4, we can convert that circle into a line. Maybe not at this time of the day.
So if I just press on it.
So you just drag your finger across, that's it. So that's you pointing to the
It's obviously
the
not.
first
It's
rib.
not a straight line.
It's not curved,
but
it's
kind of
curving
taking it
round.
right round.
Thank you. And then you were talking about the tissue. Can we see on the bottom right-hand side, I think this is from the back, can you see some of the muscles that surround the area? Where do we see those?
So that's the back of the body. That's your back muscles. You've got your scapula, your kind of wing bone that you can feel. You've got a lot of muscles that tract onto that. So when you move that, the muscles will contract. So that's this is the scapula here. And these are very large muscles that are all attached to going towards the neck and down towards the back. So these are the muscles that I looked at when I did the back dissection. This is the kind of spine coming down here. You would have had you've got skin on this other picture, you would have had obviously skin. So I've taken the skin off to look at these muscles for hemorrhage underlying.
Right. And on the bottom left-hand side, we see an image of a neck or part of a neck. And again, is that the type of tissue that is lying over and on top of the first rib?
Yeah, so you will have fatty tissue, you'll have muscle, and then you'll have skin.
And then can we look at 16, which is the next image? We may be hearing further evidence about these images, but do you see the small image there on the left-hand side?
Mm-hmm.
There is a yellow zigzag line.
Mm-hmm.
If we hear evidence that that's indicative of the area of the fracture in the first left rib, would you agree that that's reasonably
Yes.
accurate?
Yes.
Thank you. Thank you. We can leave that to one side now. Right, I'd like to move on to page 15, if I may. Now, this is a section of your final report. It covers 2.5 pages, and it's a detailed narrative part of the report, and it's headed up Final CNS Autopsy Diagnosis, Brain Evolving Global Ischemia Conclusions. I'd like you to explain to everyone what this section of the report is about and why it's in this format.
So the conclusion is the final part of the report that hopefully brings everything together. Everything from the external background circumstances, external examination, internal examination, and all the extra investigations that are undertaken. And it tends to summarise the various points that are important in the case, ultimately working up to explain why we have come to a specific cause of death.
Right. And so in this section, page 15, first of all, you talk about the circumstances, the use of PAVA and CS spray, the blows with the baton, the handcuffs, the leg restraints, and you mention respiratory arrest going into cardiac arrest. And is that a summary of the circumstances from the general background information that you've been provided?
Yes.
And
Ms.
then,
Graham, I wonder whether this might be a point
yes,
to stop, since we're on to a kind of
yes.
summarising chapter really now. So I think we'll stop there and continue at 10 o'clock tomorrow morning, Dr. Kerryanne.